We shall be having a conversation about universal health coverage shortly. Before we introduce our distinguished guest, let's hear the day's proverb.
Hakuna masika yasiyo na umbu.
Why are you looking at the guest like, so she's supposed to make that umbu noise?
No, I am looking because I am looking. The umbu story is yours.
Wow.
Just leave it at the looking bit. Now watch it hapo. Now.
Yeah.
Hakuna masika yasiyo na umbu. There is no rainy season without mosquitoes.
Right. It's true. You even have like a beat in your mind, in your head, to go with it.
Actually, yes. It is the masika that brought the tune to my head.
Which tune?
Nah, it's a Luo song.
Yeah, it's okay.
No.
So you sing it over.
No.
Come on, CT. Come on.
Don't
Ndu.
be a Debbie Downer, CT.
Okay, Ndu, I will listen to you and I will be a Debbie Downer. Nani, ebu tuendelee na mazungumzo.
Tuendelee?
Yes.
Hi, Harambe. Oh, reminds me. Yesterday, CT and I shared an oldie.
Yes.
Goldie.
While we're discussing business, Eric and I have this company.
Yeah, you guys need to be regulated.
No, we are regulated. In fact, camps are regulated us completely.
We are so regulated, we've been banned.
Yeah.
Moratorium.
And just when we were thinking of getting into the scrap metal business, now they've banned it. So we wanted to do the company. So we decided to resort to songs.
We're going to music. Now that there's a new law that's passing through Parliament that's going to say that we get 50 what percent? 52%.
Yes.
From Skiza tunes.
Yes.
That's where we're going. So we are singing the song. Harambe, 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 Moto, Moto, Harambe.
Yes.
So just come and stay with me. I don't see. Do you see? Every day.
Yeah. The man was Gideon Mwanyiga.
Yes.
And the police. And that song was all about, talking about the three ills at independence. Who first is Ujenga. Who second is Ugonjwa. Who three is Umaskini.
But
Those three.
In case the U is a bother,
Take it O.
Yes, just make it O.
Yeah. So, Ujenga, Ugonjwa, Umaskini. Let's talk about the Ugonjwa bit of it, right? And we're joined by the Health and Science Editor at the Standard Group Limited, Dr. Mercy Korir. A very good morning.
Good morning to you. It's always a pleasure to be here. I think I should come so that I balance out.
I beg my sister, just help my life.
The madness on this other side.
Please.
Yeah,
So you guys could have put in the harmonies, right?
Yeah.
When we sing Harambe.
You guys go with that?
You'll catch on. You'll catch on. Dr. Mercy, you were in Mombasa when the president was hosting a meeting that brought in the healthcare workers, and at the same time he announced a nationwide rollout of the universal health coverage. When we said that you're coming, there's actually somebody who posted a comment here in the form of a question or so and said, you know what, Dr. Mercy, just explain to us slowly, painfully, and plainly what this UHC is all about. What is it exactly?
Okay.
So start from there.
Let's start from there. But disclaimer, I don't speak for government.
Okay.
I'm only giving what I've seen, what I've learned, and the information I've gathered from speaking to the people who are, putting all of this together. So first of all, UHC, for people, they should understand, you cannot go to a hospital and say, I'm in the UHC program or I have a UHC card. UHC, Universal Health Coverage, is a policy that, should guarantee everyone access to healthcare. That means physical access and financial access, which is the affordability bit. And it should also guarantee quality healthcare services. So we are talking about availability of medicines, equipment, and every other thing that needs to offer you healthcare services. So that's in a nutshell.
Yep.
So what was happening with this scale up of UHC? Remember in 2018, December, they did the pilot in 3 counties, Nyeri, Isiolo, Machakos, Kisumu, and they are looking at different demographics, different disease patterns, and what can be done to make a program or a policy that offers healthcare work. And when they did the pilot, they did what you call input financing, where you offer resources, financial resources to the counties so that they can offer services according to the different level of facilities. Now, from that, I think it is safe to say it failed. That input financing model failed miserably. And so the thinking was input financing cannot work, it will not be sustainable. How do we make it sustainable? So this is now where the National Health Insurance Fund comes in. Notice that from the amendments that have been done through the NHIF Amendment Act, we move from hospital to a health insurance fund. So now the idea here is that all of us pull in money, which we have been doing, but now that pot will be expanded so that it's mandatory, and those who are not able to afford are paid for by government, and they've identified about 5.1 million households. They started 5.1 million households across Kenya, and it's households, not people, across Kenya, where the government will pay for them the 6,000 a year, so that they are able to access healthcare services. So they're starting off with 1 million households. So that's about 1 million times 6,000 is about 6 billion to start off, so that all of this money is in one pool. So that's one of the key things that will happen. So now from this pool of funding is where hospitals will be reimbursed according to services they've offered. And now those are the changes that NHIF has been having. Those are the conversations you've had about the complaints from the private hospitals associations about the reimbursement, saying they've reduced, because what NHIF has done, or what the government has done, is to standardize. Whether you're level 3 facility in private sector or level 3 facility in public sector, all of you are reimbursed the same amount. Let's say for delivery, for example, normal delivery will be 10,000 shillings, and a cesarean section will be 30,000 shillings. Dialysis will be 19,500 shillings a week for 3 sessions across board, so that everyone is getting the same amount of funding, so that that money now is, reinvested back in the facilities. So with your NHIF card, you're able to walk into the facility of your choice. So that is now where the capitation is. You choose if you want to go to facility A, then the health insurance, NHIF knows that facility A, for example, has 10,000 people assigned here. So assume that facility A is a level 2 facility. It's supposed to get 1,000 per person in capitation. So 1,000 times 10,000, they're supposed to get about 10 million shillings per year to offer outpatient services for the people that they have signed up. And that cuts across. So it's up to the hospitals now to work out the services that are going to offer. So that's on paper.
That's everything on paper.
Yes.
And we want to discuss kwa ground vitu namna gani. I want to ask the question about the households. What does the government put as the average number of people per household?
From that, it's 2 parents or guardians and 4 children. Those are about 6.
So 6 people in a household.
Yeah.
Okay.
Yeah.
So when you said that we're beginning the rollout here with about 1 million indigents, 1 million households as indigents, it's basically 6 million people
Yes.
as indigents.
Was it 1 million households or 5?
They're going to start with 1 million.
They're
right?
going to start with 1 million.
So they've identified 5.
5, yeah.
Okay.
5 million. So some households, maybe it's 1 person, maybe others is 2, maybe others is 6
So
or
let's cut
more.
it down, come to about 4.5 or 4 million people are going to get... What is it?
You're cutting down people.
I'm just getting down the number of persons in a household.
Arithmetically speaking.
Just looking at it and saying about, let's say, 4.5 million people. All right. Now, there's something else. NHIF has received some revamp legally. There is a new NHIF Act now, which says that everybody is compelled to contribute to NHIF.
Yes.
And would take us through that one. Who is everybody?
So everybody is anyone in gainful employment, anyone who can afford the 500 shillings a month should pay. So there are people in the formal employment, informal employment. So the 1 million and the 5.1 million households are those who cannot in any way even afford that 500 shillings. And what they said is that they worked out with the Ministry of Labour, Social Protection, Ministry of Health, and looking at the census data, they identified this number and the mechanism, and working with the chiefs. It's been a whole process, according to them, to identify these people. So now it's assuming that the rest of the households not in the 5.1 are able to pay.
Yep.
So the idea is that I think we are now about 53 million Kenyans, in one way or another, either you're paying voluntarily, you're paying because you're employed, or the government is paying for you, so that all of these funds come into one pool for that now to be distributed. And being an insurance...
Is it all Kenyans or all adults?
All Kenyans. Remember, anyone can fall sick. Obviously, it's the adults who are paying.
Right.
But all Kenyans are covered. So that if it's a newborn child, if it's an elderly person, everyone is covered. As in, leaving no one behind, basically 100%. But obviously, those who are in gainful employment or the adults...
The requirement for payment is for all adults.
Yes.
Is there, well, apart from the indigents who've been identified as those who are not able to afford to pay, is there any other category that is exempted from this? For example, is an 18-year-old expected to start paying just because they've turned 18?
No, so
and they're still under their parents' care.
If I remember correctly, there was some allowance for children who are still in school and living with their parents, who would still be covered under their parents, I think, until the age of 21 or 24. There's something. So there's an allowance between 18 and 20-something, who you can still be under your parents. Yeah. So the whole point is that everyone is covered. And this being an insurance, if there's as much money as possible being pulled in from an insurance point of view, from the exchequer, from donor funding, and it's all in one pot, then that money can now be used to offer services. The second assumption is that not everyone will need to claim or will need to go to hospital. Not everyone will fall sick. We'll see how that goes, because I know there are Kenyans who, at the end of the year, if they have private insurance, they go knocking at hospitals and say, the whole year sijakuwa mgonjwa, can you do all checks to see if I'm okay because I've not used my insurance? So hopefully those things will not arise. Yeah.
What do you see as issues that could essentially topple this apple cart? Because, I mean, you said with some guarded words there that on paper, Daktari, I mean, I know what I see, and I know that we've had conversations with you previously about, what could stop this from working in the way that it's supposed to. And I'm sure there's a list of issues that have not been addressed. What are those?
Obviously, one of the key things that has been an Achilles tendon in Kenya is in implementation. When the rubber hits the road, then what happens? So one of the main things is, one, we've seen, and I'm glad the president mentioned it, and I hope those who are in governorship listened, or those who are keen about making healthcare work in the counties listened, is that funds have not been getting to hospitals. Funds have been, they go to the county revenue pots, and from there they are distributed according to the priorities of the counties. So one of the key things that may make this work or not is if these funds directly go to the facilities. That means that counties need to pass an act to ring fence all the health funds so that all funds designated to health, be it from the budget, be it from NHIF, be it from donor funding, all of them go to the health facilities and to all the health functions. What that will mean is that as much money as possible is going to the hospitals. The hospitals are able to stock medicines. The hospital are able to, repair equipment when they're not functioning. If they have a surge of patients, they're able to contract extra staff to offer services. So that giving hospitals that autonomy is key in making this work. And I've seen it in Thailand, where hospitals basically run their own business and run their own affairs, as long as,
These are government hospitals.
Yes, government public hospitals. And that's why universal health, Thailand is one of the countries that has actually got it right with UHC. Because what they did is that all hospitals, be it a level 6 hospital all the way to, your community-based hospital, have the... So let me work from a grassroots level. Let's say the community level 1 hospital facility. They have members of the community sitting in the board of the hospital. So they represent the community and obviously with the doctors. So they work out, what do we need? What are our priorities? Their funding is according to capitation, what I talked about, which is where we're going. We're assuming that, I think the last time I checked, theirs was about 3,500 shillings per person. So if you have 1,000 people within your community, you're getting 3.5 million to offer services. And it's very clear as a level 1 facility, maybe you're doing preventive health, you're doing, talks in school about hand washing, things like that. So you have those funds to offer that services. Then your other services are to attend to emergencies and do referrals. So it means you have an emergency unit, you have good referral, an ambulance, and staff that are able to do that. So you're given money according to your level of facility. So what that does is that the community feels part of the hospital because they are represented, they have a say there. And when things are not working, the community sorts it out there. And this translates all the way up to the level 6 facilities, where now it's bigger budget, bigger, services offered, and it's very clear who is offering what kind of services. So their upward referral and their downward referral works perfectly well. Obviously, teething problems here and there, but it works. So if the same thing is replicated here, where facilities run their own business, manage their own funds, and the communities around them are involved, then you find that it works. It's been seen to work elsewhere. I do not believe in reinventing the wheel. We can adopt that and make it work. So that will be one of the key things that will make or break this. The second is how the national government and the county governments will cooperate and coordinate. We've seen issues around this. And this is particularly on healthcare workforce. And, at the same venue was a conversation about repositioning the healthcare workforce for the future and for attaining this. So we've seen issues where some counties are more resourced in terms of healthcare personnel. If you look at Nairobi and its environs, the big cities, then when you go further off, people are suffering. They do not have, the kind of specialists. So how does the government work? And Atwoli said this, that maybe it's about time to rethink of, having your healthcare workforce under a central system. Maybe it will work in that from a central point of view, you are able to you have a bird's eye view of the country and be able to distribute your healthcare workforce according to where there's need and be able to balance it out. And you're able to move
Isn't
them
that what
around.
we had before devolution?
Yes, that's what we had before devolution. And back then, okay, it's a conversation. Back then, before devolution, people could be sent to far-flung areas.
Could be sent
anywhere, and they would go and work. But now what we've seen is some counties have preference for some people because maybe they're the same tribe, maybe they know where they come from. So you find that there's a skewed, skewed distribution of healthcare workforce.
There's a rule book about that distribution as to what percentage of locals should actually be there. There's a rule book.
Yep.
30% should be from, other counties, but is it working? But now if you think about it, your healthcare workforce is limited resource. It takes time to train, all of these things. Shouldn't that be at a central place where they can be equitably distributed? But if, that's what I was saying, the coordination cooperation between national and county will be key. If the two governments can have a system or a formula that works, that makes sure that there's equitable distribution of healthcare workforce, then it will work. Because at the end of the day, what you want is, you do not want all your neurosurgeons in Nairobi as if people in Mandera do not need neurosurgeons. You need to distribute it equitably.
But
so
it
if
brings
there's
in
a
the
balance,
other question, though, Daktari, of, so NHIF revamped. We've launched UHC, scaling up Countrywide, focusing on the money side. And we even had that conversation here. How about the other side of the chain? For example, infrastructure, like you're saying. So if you send a neurosurgeon to a place that the neurosurgeon does not have everything that they need in a facility, are you really optimizing use of this healthcare worker? This is what the president said about our hospitals. And he says our public hospitals are actually so good that even the private sector is having difficulty matching up.
Private hospitals are referring their patients to some of the public hospitals because some of our public hospitals are even better equipped than some of the private hospitals that we have had. And what does all this investment mean? It means that if we continue to improve these services, we save this country money, we save our people money, which can be put to other use. We know how health has bankrupted many families, many families, because there is nothing you can do. But now we are beginning to provide those alternatives.
Ismail says, let's talk about several things. Number one, was there a report that was released after the pilot in the 4 counties? And what did it say? Secondly, what's the priority? Is it equipping the health facilities or is it rolling out the money side of UHC? Is UHC not just empty government project? Another one for campaign purposes. Number 3, you may not be able to answer. Let's talk about number 1 and number 2. Well, did you ever see a report that was released saying, this is what we found from our pilot project? And then what's the state of affairs in terms of equipping our health facilities countrywide?
No, I looked for that report of the pilot. I'm still looking for it because that report seems to be a classified document, but they've been, because we interact and talk to some of these people, so you get hints and, hints and information about what it worked. And one of the key things that the message they came out with, that input financing, which is what the pilot program did not work. And so I think, and for me, that would be like a major lesson.
Doctor, just pause a bit. Go back again. Didn't work.
Yes.
Can I interrupt you further and ask what that means?
It means,
yes,
basically,
in your view,
the experiment to see if you give counties X amount of money for them to invest or work out in health, if that would work. And it didn't, because it's not sustainable, because you have to have sort of a revolving fund. There has to be a mechanism or a way where there's always, because money, health always takes money. It doesn't give you back. It only gives you back in terms of a healthy population that is able to go and work. But in this input financing, if you take 4 billion shillings, give to each county 1 billion shillings, at the end of the year it goes. So where do you get the money back
to replenish?
But our healthcare service, even in public hospitals, is not free.
So what informed experimenting with input financing?
I wish I had an answer for that. I wish.
You see
I
why
had
I'm
an answer for
asking?
that.
You see, I know for a fact that hospital revenues in this country is significant. It is something worth bothering about. People actually pay, not as high as it pay in private hospital, but they pay.
They pay.
You see, so the issue of an input not being viable in terms of the return, that discussion becomes a bit moot. I'm not talking about input financing. I'm just talking about the general discussion around it.
So now that's what she was asking. How if this will work? And you see, hospitals generate money, but where does the money go? It goes back to the county revenue. So when it goes back to the county revenue, there's no guarantee it will come back to healthcare, which is now the conversation about ring fencing health funds so that whatever you generate comes back to you. Because if you dispense 1,000 Panadols, for example, it has given you 1,000 shillings. If the 1,000 goes to the county, you need it back for you to buy another 1,000 Panadols.
And not build a market.
Exactly. But if they don't come back, then it means next time I come to the hospital, that medicine will not be there. So it's key that money generated in health remains and continues revolving in health. And this is where the question on infrastructure comes in. For me, how I see it is a chicken and egg kind of situation where you need money. And that's why I partly support, or rather, I support this rollout or start with NHIF reforms and the money reforms, because you need money to come back to the health facilities for you to be able to improve your infrastructure, for you to be able to, buy medicines and be able to resource.
And to hire
but
more
if
people,
the money is not coming back, then you're not able to do that infrastructure.
Fine.
Sure.
Is there a plan that says that this is what we are doing? So in the meantime, as we revamp NHIF, as we get more money, as NHIF cash is then going into all health facilities in terms of capitation and all, that this is what this money is going to do. For example, let's say the basics like we saw in some of these pilot county projects. Pilot county.
Yes.
Right?
Kylet Pound.
Yes.
That
We were
works.
told,
That works.
we were told, Nyeri, there were places where those community health centers, there's a structure, it doesn't have water, not connected to electricity, it doesn't have those very basics, even disposal facilities, medicine, lab testing. So is there a plan, as we say we are rolling out, that this is what is going to happen within the next 6 months, within the next X?
So picking from the president's speech, one of the things he said should happen is that within the next 6 months, by June this year, we should have consolidated. I'm just reporting.
Go
All
on.
government programs in health into one, so that you're able to track the funds and the resources that come to it. I assume that is what he meant by that. And then the other thing was about, and he mentioned the counties reinvesting back in health. He talked about which other reforms, I don't remember, but also key for that day was they call it Kenya Health Financing Strategy, where they have a 10-year plan on how to, improve services, funding, mobilize funds into the health sector. It's a whole, policy. Somebody from MOH should be sitting here to explain that. But there's a whole 10-year plan to do that. But for me, key is that some of these reforms or changes in health take time. Countries took 20 years, 30 years to be able to get somewhere. At least I feel like if we do things right, we may accelerate actually.
We need a plan.
And
They took
there's
20
that-
years
there's
because
that
there has a
10-year
plan.
plan.
The 10-year plan is on financing, is on looking at this money that has been coming out into the HIV sector that is now dwindling from the donors. How shall we deal with that? How we are being financed by donors on blood transfusion and management. How shall we fill that gap? But we are not talking about, and I am sure the Ministry of Health has data of how many people each health facility is servicing and whether that's adequate and whether then we need to so you can map out an area in here we have no health facility, we need to build one. Here we have a health facility but it's congested, we need to increase. When they did that with NMS, it's because they had a plan. I mean, they already had data of what healthcare facilities are needed. Is there such a plan to say, we have X number of health facilities at level 1, level 2, we need to increase them to this by this time, to this by this time?
So
without that, Mercy, that's where the question of confidence comes in.
No, they have that data because I think, for example, we have about 5,700, they're about almost 6,000 total health facilities
Public
in the
health
country.
facilities.
Yeah, under NHIF. Total, I think, is about 12,000. But about 5,700 are already accredited under NHIF because there's remember they did the college KHPOA, Kenya Health Professionals Oversight Authority, that mapped out health facilities in the country. That's why you're able to tie according to level 1 to 6, you're able to know. So that data is there. And if you ask me, I don't think this country needs any more health facilities to be built, quite honestly, because we have more than enough. What needs to be done is to make sure that those that are there actually work. If you take Nairobi, for example, CBD, it has two facilities that hardly anyone goes to. There's Lourdes, I think Lourdes Casino. City would know them. They are there, and I know I'm saying City would know them.
Yes.
If you
City,
go to
where is Lourdes Casino?
You see, some of these health facilities she speaks of are known more for facilitating research into STIs and some of these diseases that you find that are common in a society. So she is right when she points to me and says, he would know. And now the two of you also
know.
Yes.
Yeah, if you go upstate House Road, there is Lady Northy. It's a whole big facility there that is hardly used. Langata Health Center. It's a big facility.
Center.
It's a big facility, which should actually even rival Mbagathi. So you have many facilities that are not
being optimized.
If you go to counties, it's even worse. When an MP comes, they set up a facility nobody uses. So there are many structures. So the key thing would be to make sure that those that are already there work.
And that's the
So
question
what
I'm
would
asking.
be?
Is there
How
a
would
plan
it
like
be?
that?
Because I mean, even as you're saying this now, for example, you've got facilities in Nyeri, because essentially with UHC, that at whatever level, that if I go into a dispensary, for example, and I have a cut that needs to be sorted out, or they need to check this, or it should be able to be done and everything should be there, right? So do we even know? And that's what I hear and I understand about the plan. Do we even know the facilities that are existent? Is it somewhere tabulated?
Yep.
Because we have a facility, swanky new facility in Nakuru that's now a poultry. Another one in Marsabit that is empty, has nothing even plugged in. You have open wires.
Others have vegetation growing.
So, another one, a tree grows in the middle of it. It's actually a book. A tree grows in the middle of it, right? So, is there a plan?
A new one
Is
in
there
Kakamega
something-
that's just a key structure, incomplete.
They're there. The government has a big map of where all the facilities in this country are.
They know.
They know some of them. Even I would not be surprised if the one where there's poultry or there's a tree growing in actually has staff on a payroll working there.
As to whether they actually are there physically, is a completely different matter.
That is the story. That is the whole thing that we need to work out, because staff are there. Some are on a payroll. But you see, as a user, if I go to dispensary X today for a cut, and I'm told, go to the other one, come back tomorrow. If I come back tomorrow, I'm referred elsewhere. I'll not come a third time.
Of course.
And so, over time, they're not being used. And that's why you find that people crowd the level 4, 5, 6 facilities. Yet, at a downward level, they work there. For example, a level 6 facility, KNH, should just be a purely referral facility. Why does it still do vaccinations, for example? Yet, if you're just looking at Nairobi and its environs, there are many health centers. If you go to South B, if you go to South C, there are health centers which should be carrying out that. There's no need for you to go all the way and Kinich for vaccination of your child. So there are some of these systems that need to be ironed out. And that's why I say how national government and county government cooperate will be key, because a downward referral should be able to work. Like if you've been discharged with a wound, why are you still going back,
Don't come back
to level 6
Yeah.
for wound cleaning? A dispensary should be able to do that. But it can only do that if the staff are physically present.
Right.
Those who are not, if it's not resourced staff-wise, it is resourced. And the commodities,
have
the
the bandages.
pharmaceuticals that they
At the very
need
least.
are supplied.
So, from a medical perspective, Dr. are you comfortable to say that, because around the country that you can go today, with how this has been rolled out, let's take something like dialysis, that we see people troop to KNH coming up from different parts of the country, come to Nairobi to get their dialysis done on a weekly basis. Are you comfortable to say, enough to say that around the country, you actually don't have to travel from where you are to come to KNH to have your dialysis done?
For dialysis, yes. Remember the controversial MESS project,
Yes.
the managed equipment scheme, where at least 2 facilities in every county were being equipped. And they actually were equipped with all of those surgical dialysis, all of those things. But now it was the installation and use that was taking time. And so with this, if they accelerate so that those that are not yet installed for use are installed and actually used, then people will not need to. And we've seen improvement, I would say, from, let's say, 4 or 5 years back to now, where there's a lot more happening, because the nurses and the doctors who are undergoing training for renal care have already finished.
Yeah.
So we should be able to now actually utilize fully those facilities that are there, because the money was there, the installations were done, the changes were done in some of these facilities. So they should be able to decongest and work that out. But dialysis is a whole other conversation, because dialysis should transition you to a transplant. So if we start talking about, because you should not be on dialysis perpetually, which is now what I was asking NHIF, is there a plan to transition these people to a transplant? Because the transplant, you never need to go for dialysis
again.
So the challenge has been NHIF pays for your dialysis, but does not pay for your post-transplant medicines. So what happens? The kidney fails
again.
You're back to dialysis.
Let me perhaps move a
Those
few
are wasted organs.
Absolutely. Let me take you a few steps before that. The preventative aspect of this. This is, as you know, a favorite topic of mine. Now, we know what causes kidney failure. We know what causes, let's say, renal failure generally, okay? Now, does this government have, does the health sector have in place policies that would,
That would?
But
enable them to ensure,
this country has some
That
of the
we-
best policies.
Wait, let him finish the question.
okay, once upon a time, that would enable health practitioners and the support system that they have to ensure that this very process that we're now discussing is actually nipped in the bud, so that as much as possible, people who end up in the care and treatment program for renal problems are weaned out or are reduced to a bare minimum.
This, if there's something that this country has in plenty, is policies. They're very good policies. The NCD, cancer, all of those things, they're there. But the challenge has been in, one, actually implementing because of lack of or inadequate resources. Two is this country has many
Which
donor
resource
programs.
in particular are you referring to?
Money. And I'll give you an example of that. Then there are many donor programs in this country which run their own parallel things. So you find so many things happening, but they're not communicating with each other. Now, on the money resources, I covered a story in West Pokot about cholera. There was a cholera outbreak. Now, when I talked to the public health officers, they told me that they are unable to move around to schools, and they are on motorbikes because they do not have fuel for their motorbikes. Yet, they are on a payroll. They actually report to work every day just to sit around. But because they don't have just fuel to move around, to talk to students about hand washing, building latrines and things like that, there was a cholera outbreak.
By the way, let me just confirm.
This just needs fuel.
You're talking of West Pokot. What you're discussing, a point I experience literally on a daily basis in some of the places I've worked in. You even fuel that vehicle, you even fuel that motorbike, and 2 days later, you're told, we need fuel again. And you ask, but the fuel was for this. And you're told, no. When we got the fuel, we were now enabled to do this, and the other. And then in some places, you fuel the vehicle, and there are 3 vehicles working. The MedSoup decides that one vehicle is now for them to be able to move around and do God alone knows what they are.
Inspect projects.
Yes, exactly.
To inspect.
So, yes, it is a problem. But then again, when you ask, there was an allocation for fuel. Now,
Where does it go?
If you have a generator, the story is even more interesting.
Oh, yeah.
How important, Doc, is communication in this whole UHC thing? Because we always talk about you're setting out a project like this. It is important for the communication aspect to be just as strong, because you will still have that mother who is traveling from Muranga to KNH to have her baby inoculated for rubella, mumps, and she'll go and do that. Not because, only because she's not aware that you don't have to go to the big hospital to get it done, that you can get just as good a service in your local area. How are we going to start communicating some of these things?
Now, the Ministry of Health, the county governments need to up their game and start talking to people. The other day, somebody was surprised when they went to a public hospital for services. They only paid 200 shillings, I think, to open a file. They were out because they were on NHIF. So they were like, if I had gone to a private hospital, I would have obviously called for Harambe. Then it's like, I didn't know you could actually do that. So it's up to the government for them to make sure this works, that they talk to us. And 2, for us to know that we deserve those services. We have a right to those services. So if you go to your facility, they're not doing you a favor. You've already paid tax for it. You're already pre-financing through NHIF. So it's for you to demand those rights, those services. And if it's not working, to hold the people there accountable. So it has to be two-way. Government has said UHC is here, or you can access services. We've made all of these changes in NHIF. Then it's up to me to say, I've paid 500 shillings. Why am I not getting...
I get everything. I go in there.
Exactly.
The lab is there. The medicine is from there. Not that you go to a private lab, then go to look for medicine.
We have to start demanding for these things as wananchi. Otherwise, people will get away with things, fueling vehicles to go and do their own things instead of working for us.
Right. As we conclude, let's talk about the health workforce. All right. So the president has said we are training very many people in this country. We have many who've been trained who have not even been absorbed. Is this the case?
Yes. We have... everything in government works with budgets. So you find they say we don't have a budget for this. There's a need for that healthcare workforce, but they say they don't have a budget for it. So for me, it boils down to planning, and being able to see that in X number of years, you need to be at such and such a place so that you plan accordingly to that. But now it comes back to what are your priorities as a county, because now the health workforce really is a county issue. What are your priorities per county? Some of these people that counties or government does not absorb go out of the country and they become some very serious big people out there doing wonders in healthcare. So you wonder, had they been given an opportunity here, then the country will be different. So it's about planning, prioritizing, and maybe that's why the conference was there, so that this healthcare workforce, because it brought everyone from medics across to nurses, clinical officers. How do you make this workforce work for you? And especially if you want to be offering, services under universal health coverage.
So let's take a break on KTN Home. You've been with us since the top of the hour, but the conversations continue on SpiceFM. And as we conclude the week, wishing the audience on KTN Home all the best, listen to what the president said, especially about the health workers in this country.
We have the caliber of professional health worker that is able, operating within the environment we are providing and upgrading our hospitals, that we have trained men and women who can utilize this equipment and provide the best healthcare systems comparable to any part in the world. And I'm sure we can. Canada, the United Kingdom, Australia, they wouldn't be here trying to get our nurses to go and work in their hospitals if we were not producing good quality people. We are producing. What we need is to ensure that the skills they have are equivalent to the kind of technology that is available out there. And they, in turn, will be able to provide our people with the same level of service as they are capable of delivering out there.
So there you've heard the president talking about we have some of the best healthcare workers that can be trained by any country anywhere in the world. And some of them even go and work abroad. We have those who are going to work in the UK with a government program with the UK government. So we have the personnel.
Eric, not to sound rude, the president was telling something we know. Not to sound rude, okay? To understand how very well-trained human resources in this country look at our remittances and look at the place, the part, the role they play in this country's development. It tells you that people trained in this country are welcomed elsewhere and they do a splendid job. That's why remittances are on the up, not on the down. We know. Okay? And thank you. We do know. However, it is not that knowledge we need. What we need is a clear commitment of how we are going to actually take advantage of this particular resource that we have and fill in gaps like with community health workers that we don't have. When people talk about budgeting, Dr. Mercy, we had a problem with the blood donation services in this country. And when we asked, do you know that story of budgeting came into play? Yes. And you wonder, what? How is it possible for this not to have been budgeted for? Yes.
Let's continue the conversation in the next hour. And when you hear the president saying, we have the best facilities, even the private sector is actually referring people into our public health facilities, that tells you we have the best. We ask ourselves the question, Mr. President, have you ever used a public health facility? Have you? Mr. Muthui Kagwe, when is the last time you used a public health facility?
For even a cut on
Dr. Patrick Kamoth, when did you last? Because if they don't, that's why the first thing that they think about is, oh my God, our private is actually even sending people to those places.